Hello everyone, welcome to the Anatomy Interactive Learn and Practice session. Although we have already covered anatomy in our course, but this is a practice session. Actually, this is an open session for everyone. So just a quick revision of few important points of anatomy. I would rather say just a random revision and to give the idea to the new students that how they can actually learn in a fun way. Like it is going to be a fun session. More, we'll be talking of questions, we'll be talking of some mnemonics, and we'll see how important it is to read about the diagrams. So you should study anatomy with the diagrams because in exam also you have a lot of pointers with the diagrams and you should be able to recognize structures. So therefore, the session is largely based on that. There are going to be 20 questions in a row and it's going to be completely interactive session. I would like you all to volunteer for the questions so that you read, you answer, and then we discuss. Okay? So all set? Are you all ready? Yes or no?
Yeah.
Yes? Yeah,
Yes.
that's it. Okay. So who will take up the first question? Who would like to take up first question? See, it's going to be very easy questions. I think those who have done the classes, they know all the answers. So don't worry. Anybody would like to volunteer? No volunteers? Or it's going to be interactive then? Yes, any one of you. I promise it's absolutely easy. Oh, yes, Dr. Prithvi. Very nice. Good. It's going to be very, very easy. See? So fallopian tube is lined by. Yes, you have to read the question yourself and answer. Yes. Yeah, you can unmute and speak.
Ma'am, simple columnar.
Right. So fallopian tube is lined by simple columnar epithelium. Okay. Rest all of you can answer in the chat box. Everybody agrees to this?
Yes.
Dr. Adi, what is M? You would take next question? Okay, so C, yes, columnar. Columnar is correct. So absolutely correct. Right. So it's going to be simple columnar epithelium. Good. So next one, Dr. Adi. Are you okay? This is the next one. Who is going to answer? Oh my God, these are so simple and so direct questions, isn't it? Anybody? Vagina is lined by?
D. Stratified.
Yes, stratified squamous. It is keratinized or non-keratinized?
Keratinized.
Keratinized? So it is non-keratinized, right?
Okay.
Stratified squamous, non-keratinized, only near the introitus where the hairy structures are there, the skin appendages are there, there it becomes keratinized. It is only as you reach introitus. Otherwise, the complete length of vagina is stratified, non-keratinized squamous epithelium. Right? Am I right?
Yes, ma'am.
Yeah. Okay. So urinary bladder is lined by?
Transitional epithelium.
Stratified transitional epithelium.
Yes, stratified transitional epithelium. Very good. So here is the quick review of all types. So simple squamous epithelium. This is usually present in the air sacs of the lungs and the lining of heart blood vessels and lymphatic vessels. The main function is diffusion of the substances across it. Simple cuboidal in the ducts and secretory portions of small glands and in kidney tubules. It secretes and absorbs. Simple columnar epithelium, this is ciliated tissues, are in bronchi, uterine tubes, and uterus. Smooth, non-ciliated tissue is present in digestive tract. So pseudostratified, this is usually limited to the respiratory system. So only in the trachea and the respiratory tract. So we talked about simple columnar right now. Stratified squamous is present in esophagus, mouth, and vagina, and it protects against various aberrations. Then transitional is important, which lines the bladder, urethra, and the ureters, right? So all the important, these are all summarized in this table. And one question from the histology generally comes, either by this type of epithelium or maybe in pathology when we talk about the endometrial hyperplasia. So that histology is also very important. So these all will form the, you will have a one question from this type of thing, one of the question from histology. Okay, now clitoris drains into
Deep inguinal.
So B is the correct answer.
Yes.
Okay, so what is the lymph node known as?
Clocket. Lymph node of clocket.
Lymph node of
Yes.
clocket.
Yes, it is known as lymph node of clocket. Arjun is very fond of using these terms. So if any specific term or some name is there, so it becomes an important exam question. So deep inguinal lymph node, clitoris drains into, so it is B and it is lymph node of clocket. Vulva drains into.
Superficial inguinal lymph node. A.
Fine. Everyone agrees to that or any other answer?
Agrees. Superficial.
Everyone agrees. Superficial inguinal lymph node. So that is the correct answer. So basically, we have to understand that when we talk about vulva, there are multiple different segments, right? So superficial inguinal lymph node, some of it goes to deep inguinal as well, and some directly goes to external iliac. But when we talk about the clinico-pathological point of view, like how to check like sentinel lymph node biopsy and all this, then superficial inguinal lymph node is the most nearest one, and that is the first place where the lymph goes. So this becomes all the more important.
Okay.
Lymphatics of each side freely communicate with each other, and the lymphatics hardly cross beyond the labiopleural fold. Vulval lymphatics also anastomose with the lymphatics of the lower third of vagina and drain into external iliac nodes. So as you have seen, I've shown that there is a drainage to the external iliac nodes as well. Lymphatics from the deep tissues may also accompany the pudendal vessels, and pudendal vessels are coming from internal iliac.
Internal iliac.
Yes, great. So it will also go to internal iliac. But superficial inguinal lymph nodes are the primary lymph nodes and they are the sentinel lymph nodes of vulva. What are sentinel nodes?
The lymph node which drain first
First draining.
from the structure.
So what is the significance?
If the sentinel lymph node is positive in cross-section cytology.
Yes.
Oncosurgery.
Yes. So if you are not sure whether the lymph nodes are involved, like if radiologically there is no lymph node involvement and you don't want to go for lymphadenectomy, then sentinel lymph node is one thing which will decide whether you need it or you don't need it, right? So you introduce a tracer dye which will go to the nearest lymph node, the first lymph node, which is draining that particular area, which is usually one of the lymph nodes of this particular group, superficial inguinal lymph nodes. And then once it is stained, you know that this is the first draining one. and then you can do the biopsy then and there and see if it is involved. Then you know that the lymph nodes are involved, you can proceed with the lymphadenectomy. If it is fine, then no need to go with the lymphadenectomy. So that is the significance of sentinel lymph node biopsy. Right? Clear to everyone?
Yes.
Yes, ma'am.
Okay. Cervix and the upper 1/3 of vagina drain into?
Okay, but
Cervix and upper 1/3 of vagina to drain into?
Internal iliac
Yeah.
node.
Okay.
Mm,
all of the above.
So I have two answers here, C and E. Which one has more votes? How many of you would
C.
like to go with C?
All of the above.
And how many would like to go with E? I have two E in the chat box. Yes. More E. So E is basically a correct answer. Although the predominant one is internal iliac, but lymph goes to all of these. If all of the above is not an option, then we can choose internal iliac nodes. But since all of the above is an option, so always remember the concept of single best answer. You have to choose one best. Okay. So here they haven't mentioned it goes predominantly to or most of the lymph goes to, no. They are just simply asked that cervix and upper 1/3 of vagina drains into. So you have to cover all the areas where they are draining. So these are the multiple nodes where the lymph goes. So the best answer to this question would be all of above.
Above. Okay.
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 So let's see. This is how the drainage is. And these are the external iliac, superficial inguinal, sacral, external, internal iliac, all these. So to remember, this is easy mnemonic. So USA, me, lies. Okay. USA, me, lies. So U stands for upper portion of the uterine body. It goes to aortic lymph nodes predominantly. Fundus and superior anterior body goes to aortic lymph nodes. While the cornu, it is draining into the superficial inguinal lymph nodes. So upper, superficial and aortic, right? So I'm just for 1 minute, I am muting, right? Because there is some disturbance. You can unmute when you want to speak. Okay, so basically to remember it, USA, so upper portion, superficial inguinal and aortic. So fundus and superior anterior body goes to aortic nodes, while cornu, from the cornu, it is going on to the superficial inguinal lymph node. Why this is so? Why so? Lymph from cornu going on to the superficial inguinal lymph node. What structure from the cornu grows to the?
Fallopian tube.
No.
Round
Starting
ligament.
for cornu
Round
and
ligament.
goes to inguinal region.
Round ligament.
Round ligament.
Yes,
Ligament.
it is because these lymphatics are draining along the round ligament. Right? So therefore, this drainage is superficial through the superficial inguinal lymph nodes. Right? Sometimes the question also comes for the lymphatic drainage of round ligament. Then you have to choose superficial inguinal lymph node. Right? So this is a point to remember here. Then you come to middle. So we said USA, so upper, superficial and aortic. Now coming to me, so middle portion, external iliac nodes and lower portion cervix going to lies. That is internal iliac, external iliac and sacral, right? They also go to obturator as well, right? So internal, external and sacral. So this is how it's an easy way to quickly remember the lymphatic drainage. Fine with everyone? Okay.
Yes.
Now you won't get confused.
Hmm.
Lymphatic drainage of vagina, it can be divided into three. So upper one goes along with the cervix, so internal, external, and obturator. Middle third predominantly goes to internal iliac. Because see, if you remember, vagina is supplied by vaginal artery in the upper 2/3. So vaginal artery is a branch of
Internally.
either it is a branch of internal iliac directly,
Or
anterior
it
division,
may be
or sometimes
inferior
it is from the uterine artery. So
uterine.
either way, it will follow the internal iliac.
Internally.
Yes. So either way, either it is coming from the internal iliac or it is coming from the uterine. The lymph will go to internal iliac nodes. Now the lower third will come to the perineum. So that is with the vulva and perineum to superficial inguinal lymph nodes, right? What is the vessel supplying here?
Perineal branch of internal pudendal artery.
Very good. Perfect. Absolutely correct. So internal pudendal. Always remember all the perineal structures are supplied by the internal pudendal artery. It's branches of internal pudendal artery. So just remember this. So you will be able to answer. Good. All well? All clear? Any doubts?
Yes, ma'am.
Fine?
Hmm.
Okay. So oxygenated blood from umbilical vein to inferior vena cava is bypassed by
Ductus venosus.
Yes, arteriosus.
fetal circulation is very, very important part. But, yes, particularly these 2-3 structures, ductus venosus, your ductus arteriosus, foramen ovale, so they are important structures. And questions do come from that, and many times a diagram of fetal circulation is there with a pointer on it. So you have to identify these shunts in the diagram. So absolutely correct. This is ductus venosus. Okay, so from the umbilical vein to inferior vena cava, it is ductus venosus. What is the remnant known as?
Ligamentum.
Ligamentum venosum.
Correct. So it is ligamentum venosus. So ductus venosus becomes okay. So next question is the same. So ligamentum venosum, you all have already answered. So here's the basically diagram. So this is basically the ductus venosus here. So, and this is foramen ovale. So all these things. Ductus arteriosus here. Obliterated remains of urachus are known
Median
as
umbilical ligament.
Median
median
ligament.
umbilical ligament. Correct. Median umbilical ligament. Again, very, very important thing. So this is a summary. Foramen ovale becomes
Fossa
fossa
ovale.
ovale. Ductus arteriosus becomes ligamentum arteriosum. Umbilical artery, medial. Yes, medial. Urachus was median.
Median.
Umbilical vein, what is it?
Ligamentum teres.
Ligament teres of liver or round ligament of liver. It is also known as round ligament of liver. And ductus venosus becomes ligamentum venosum. So one of the question is going to definitely come from all of these. Okay. So very, very important points for exam. Okay. Some landmarks. So aorta enters abdomen at
E. T12.
T12. Correct. T12. Yes. And what about inferior vena cava?
8.
Yes. It enters T8.
T8.
And what about other third structure which pierces diaphragm?
Esophagus T10.
Yes, very good. Esophagus is T10. So 8, 10, and 12. 8 is IVC, 10 is esophagus, and 12 is aorta. Correct?
Yes.
Celiac artery, a ventral branch of aorta, arises at
L1.
right.
Yes, ma'am.
Okay.
L1.
L1.
L1, L2, and L3. Celiac artery, superior mesenteric artery,
and
Inferior
inferior
mesenteric
and
bifurcation.
inferior mesenteric artery. Aorta arises and divides into right and left common iliac
L4.
artery at
L4.
L4.
okay.
Yes.
Everyone okay?
Yes.
L4? Correct. So
Yes.
T12 it enters, L1, 2, 3 it gives branches, and L4 it divides.
Divides.
Okay.
Hmm.
Okay. So common iliac artery divides into external
Sacroiliac
and
joint.
external iliac artery
Sacroiliac
at
joint.
Sacroiliac joint.
sacroiliac joint. Very good. Sacroiliac joint. Presenting diameter of fetal skull is smallest with following
Vertex.
presentation.
E, C, and B both.
Hmm. Answer is already there, sorry. So,
Oh, yes.
yes, so it's written there. So, okay, so C and
B.
C and B, both is correct. What is the diameter?
9.5.
9.5 centimeter. Very good. So, it is vertex and face. Both are 9.5 centimeter, right? So, that is the smallest diameter. So all the diameters of the fetal skull and their presentations. Very, very important for exam. So suboccipitobregmatic 9.5, occipitofrontal, suboccipitofrontal 10.5, occipitofrontal it's going to be 11.5 is 5 centimeter and deflexed vertex. Mentovertical 13, bro and submentobragmatic 9.5 centimeter and face. Another mnemonic to remember this, larger the alphabets, larger the diameters. So diameters with sub-prefix are smaller than the counterpart without it. So mento vertical is the largest one, 14 centimeter. Submento vertical, it's smaller than that because we said as the sub is added, it becomes smaller. So it becomes 11.5. Then comes the occipitofrontal. So occipitofrontal 11.5 centimeters and suboccipitofrontal is 10.5 centimeter. Then suboccipitobregmatic 9.5 and submentobregmatic is 9.5. Right? So all of these are here. Diameters of engagement. There are 3 diameters: bimastoid, bitemporal, and parietal. So just to remember the diameters, MTP, mastoid, temporal, and parietal. So mastoid is 7.5 centimeter, temporal is 8 centimeter, and biparietal is 9.5 centimeter, right? So easy to remember. Okay. Aspiration or insertion of chest drain is usually done through mid-clavicular line, 5th intercostal space by running needle or drain over the rib, mid-axillary line, 5th intercostal space by running needle or drain over the rib, then mid-clavicular line and 5th intercostal space below the under the rib, then mid-axillary line, 5th intercostal space by running needle or drain under the rib, and mid-clavicular line, 4th intercostal space by running needle or the drain over the rib.
B.
D.
B
It's a
or
B.
D? Two answers you just told me, na? B
D.
and
B. 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 It's a
Mid axillary, 5th intercostal under the rib.
okay. So B and D. Anything else?
Service over the rib. Okay.
Why we are going over the rib and why we are going under the rib?
Vessels, neurovascular.
Neurovascular specific.
So where are the vessels?
Under
Under
the
the rib.
Vessels are running under the rib. So we have to.
So drain over the rib. From B is the answer.
Yes, absolutely correct. Because the vessels are going near the
Under the
lower
rib.
border of the rib,
Hmm.
right? So we have to go on the upper
B.
border to be safe. Yes. So B is correct answer, right?
Yes.
Here is the diagram. So you see here are the vein, artery, nerve. This is the neurovascular bundle here. So we have to go over the rib, right?
Yes, ma'am.
Fine.
Okay.
Transpyloric plane is usually present hand breadth below xiphoid process at 9th costal cartilage, and it marks termination of spinal cord, and it corresponds to the vertebral level of
L1.
L1.
7 days. এখানে দেখো 7 days.
Yes, L1 is absolutely correct, and one of these marks, L1, L4 for aortic, one of these is going to come in exam. Okay, so one of these marker is definitely going to come in exam. So we are actually focusing here in this session on the questions which have to come in exam, right? So you should know all these levels very well. So B is the correct answer. Transpyloric level indicates, what structures you
All of the
find
above.
here?
All of the above.
All of the above. Yes.
All of the above. Good. So pylorus of stomach, duodenal fracture, fundus, and renal hyla, neck of pancreas, all of the above. Although I think it is easy to remember if you just imagine this plane, but still I got to find a mnemonic, so I'm just sharing it here. Like if it is for somebody, if it is difficult to remember, then this is a good way of remembering. Transpyloric, that is what we call as. So T is termination of spinal cord. Renal hilum, left only. There is transpyloric plane, goes through only one hilum, that is left, as the right kidney is slightly lower. Artery then comes after renal hilum is the A. So A artery, it is superior mesenteric artery. Then comes the N, so 9th rib. Then comes S. S, there are three structures: splenic flexure of colon, splenic hilum, and second part of duodenum. Then comes P. So P is pylorus of stomach, portal vein origin, and pancreatic neck. Y stands for nothing, right? There is nothing for Y. L is L1 vertebral body and hepatic flexure of colon. So just to remember, it is kept as L. Liver. O is Odai, the sphincter of Odai. R is root of transverse mesocolon. I is nothing, and C is again cisterna chyli. A bit more explanatory, but it's okay. Transpyloric is easy to remember. So if somebody is facing issue, otherwise with diagram also it is very easy. But just to add on this, right? Okay.
Yes.
Good. So somebody. Yes.
Lateral to McBurney.
Lateral to the McBurney point.
Injury to the inferior epigastric vessel.
Yes. So again, this is a very favorite question of RCOG. Internal epigastric vessels is very favorite. So it has to be lateral to McBurney's point. And where is the McBurney's point?
Medial 2/3 and lateral 1/3 of the spine
Hmm.
umbilical line.
Distal 1/3 of the spine umbilical.
Yes. So if you join a line between the umbilicus and the anterior superior spine, the junction of medial 2/3 and lateral 1/3. So we have to be lateral to McBurney's point. And the same thing is also important when we talk about the secondary port insertion in laparoscopy. Yes. Then also we have to take care of this vessel. Otherwise, this is a common vessel which can be injured. and leading to hemorrhage. So therefore, it is favorite of RCOG. So what about the Palmer's point? There was another name here, Palmer's point. So what actually the Palmer's point is?
Mid
Line joining the umbilicus
clavicular
and the intersection of mid axillary and the subcostal plane.
mid clavicular.
Yeah, mid clavicular and subcostal plane.
Yes, this is mid-clavicle. This is subcostal, right? So
Yeah.
basically 2 centimeter below that. Okay. So it is 2 centimeter below that. So now at this point, what will you encounter? There is, if the spleen is enlarged, then you can encounter that, right? So any surgery in the spleen or splenomegaly, then this is a contraindicated. What are the indications when we go for the Palmer's point?
Previous surgery causing adhesions.
Yes, when we expect that there are adhesions here, right? So when we expect that there are adhesions, like there is already an incision or some surgery, so then in that case, we can choose to go with the Palmer's point. Pyramidalis is supplied by
Subcostal nerve.
Subcostal nerve.
subcostal nerve is the correct answer. What is the arterial supply? What is the arterial supply of pyramidalis?
Inferior epigastric.
Yes, perfect. Very good. It's inferior epigastric artery, right? Another important question for the pyramidalis is, what percentage of population have this muscle?
50%.
20%, as per RCOG data. 20% population have pyramidalis, only 20%, right? Very unusual question, but it's a recall question of RCOG exam, right? So 20% population, it is supplied by subcostal nerve, and it is basically the arterial supply is inferior epigastric artery. Inferior epigastric artery is a branch of
External iliac artery.
external iliac artery. Good. Okay, so this is last question for the day. So which of the following is not component of spermatic cord?
Inferior epigastric artery.
Inferior epigastric artery.
Yes, correct. Inferior epigastric artery. So already we have learned rule of 3 for this. So the memory tool to remember the contents of the spermatic cord is 3 arteries, 3 nerves, 3 fascias, and 3 other things. So 3 arteries are artery of ductus deferens and the testicular artery and cremasteric artery. 3 nerves are genital branch of genitofemoral nerve, parasympathetic and sympathetic nerve fibers. 3 fascias are external spermatic fascia, cremasteric fascia, and internal spermatic fascia. And 3 other things like ductus deferens, pampaniform plexus, and lymphatic vessels. So that was a quick short session to give you a quick review of some of the important anatomy questions. I hope you all enjoyed.
Yes,
Any
ma'am.
questions from your side? All well?
Yes, ma'am.
Okay.
Yes,
So,
ma'am.
yeah. Anything you guys want to ask? No?
No.
Okay. Okay. So that was all for today. Okay.
Thank you, ma'am.
Night, ma'am.
you.
Thank you, ma'am.
Thank you for joining. Thank you. Good night. Take care. Bye.
Thank you, ma'am. Good night.